We described the pharmacokinetic and pharmacodynamic properties of antimicrobacterial agents and differentiated between latent tuberculosis and active pulmonary tuberculosis infection. We also initiated a medication regimen in a patient with latent tuberculosis infection. Now, given an active pulmonary tuberculosis patient case, recommend ATS-CDC-IDSA guideline-concordant first-line therapy. The goals of therapy include rapidly reducing the number of actively growing mycobacteria and eradicating populations of persisting bacilli in order to prevent relapse and to prevent acquisition of drug resistance during therapy. There are two things that are associated with increased risk of relapse. One is signs of more extensive disease, which is typically cavitation or more extensive disease on chest radiograph, as well as slow response to treatment. So typically delayed culture conversion at 2 to 3 months after treatment. The treatment of active tuberculosis includes an intensive phase of RIPE. So RIPE stands for rifampin, isoniazid, pyrazinamide, as well as ethambutol. By the end of the intensive phase, which typically takes about 2 months, the results of susceptibility will be back, and by then it will be known if the mycobacteria are susceptible to rifampin and isoniazid. Until then, it is important to have pyrazinamide and ethambutol to make sure that there is sufficient coverage of mycobacteria. Beyond the intensive phase, there is the continuation phase that typically takes about 4 to 7 months, depending on how the patient responds to treatment, and consists of combination of isoniazid and rifampin for drug-susceptible tuberculosis. We will not discuss multi-drug resistant tuberculosis in this topic. If the cultures are negative by the end of the intensive phase, a short duration of 4 additional months for continuation phase will be sufficient for a total of 6 months. So 4 months of continuation plus the 2 months of intensive phase. However, if at 2 months the cultures are positive and there is cavitation, that is an increased risk of relapse. So extended duration of therapy is needed. So 7 months plus the 2 months of intensive phase will result to a 9-month total duration of treatment. So the intensive phase consists of 4 drugs, RIPE. However, if the culture results come back for the susceptibilities prior to the end of 2 months, and it shows that the mycobacteria are susceptible to isoniazid and rifampin, ethambutol can be discontinued. So ethambutol is the most toxic. So it is important to discontinue ethambutol as soon as the susceptibility results suggest that it is safe. Because isoniazid is an important part of treatment for the entire duration of therapy, it can lead to neuropathy during this long duration of therapy. And it is important to give pyridoxine, which is basically vitamin B6, to patients who are getting isoniazid, especially for patients who are at increased risk of neuropathy. And those include patients who are pregnant, breastfeeding, persons infected with HIV, patients with diabetes, alcoholism, malnutrition, or chronic renal failure, as well as those who are of advanced age. Because the duration of treatment is very long, there are various regimens that have been studied, including regimens that are given daily, as well as more sporadically dosing, including 5 days a week, 3 times a week, and even 2 times weekly. And of course, the effectiveness of the regimen increases with increased frequency. So by far the best regimen that's recommended is the once daily regimen for the entire duration of treatment. And the reason the duration of treatment is so long is because mycobacteria population basically consists of actively replicating bacilli and non-replicating bacilli. So during the intensive phase, pretty much the actively replicating bacilli will be dropped. However, because the non-replicating bacilli will not be killed and it takes a long time for them to become active, it is important to continue for a long period of time in order to eradicate all these non-replicating bacilli. So as they become active, the antimycobacterial agents will eradicate them. And that is important to prevent relapse. Of course, with the long duration of therapy, there is a concern for adherence. It is very challenging for the patient. So there is the concept of self-administered therapy versus directly observed therapy. And there has been a lot of studies done and comparing the two strategies. And the guidelines actually recommend that the directly observed therapy is preferred over self-administered therapy in order to improve adherence, which would reduce the risk of relapse. And DOT can be provided in the office, clinic, or in the field, for example, in the patient's home, place of employment, school, or any other site that is mutually agreeable. And this is very variable, so it, depending on where the patient gets treatment, this can be set up in order for the patient to receive their medication daily as DOT. So as I mentioned, it is preferred that the patients receive the daily rather than intermittent dosing of these regimens. However, some patients, it may improve adherence if they take it 3 times weekly or thrice weekly. However, if the patients are to get thrice weekly, it is recommended to only do this in patients who are not infected with HIV, because in HIV population, we have seen increased risk of relapse with intermittent dosing. And of course, as a last resort, if the patient is not able to do either daily or thrice weekly, as a last resort, twice weekly is also an option. But again, not in patients with HIV, and it is not recommended in patients at high risk of relapse. After the 2 months of intensive phase, the continuation phase can be either 4 months or 7 months, and it is recommended to extend to the 7 months for patients who are at increased risk of relapse, including patients who have cavitation on the initial chest x-ray, and those who have positive culture at completion of 2 months of therapy. Additional factors to be considered in deciding to prolong treatment in patients with either cavitation or positive culture at 2 months, but not both, might include more than 10% below ideal body weight, active smoker, diabetes, HIV infection, or any other immunosuppressive condition, as well as extensive disease on chest x-ray. As I mentioned before, it is recommended to use daily regimens or thrice weekly if the patient cannot do it daily. And thrice weekly is preferred over twice weekly, but definitely once weekly is not recommended. So the guidelines recommend against use of once weekly because of increased risk of relapse. Here's a chart for monitoring that's recommended in the IDSA guideline. The shaded boxes are recommended only when necessary, whereas the other unshaded boxes are recommended. So there are recommendations at baseline and then at the first month, second month, and so forth. So it is recommended for when it comes to symptoms, it is recommended to monitor the patient's weight at baseline and monthly, because weight loss is a symptom of TB. Other symptoms and adherence review at baseline and every month throughout the treatment. Vision assessment is very important when the patient is on ethambutol. So typically the first 2 months when the patient is getting ethambutol, and beyond that only if the patient needs to continue ethambutol based on susceptibility results. For sputum smear and culture at baseline and monthly, and then beyond 2 months only if it's not negative by the end of intensive phase. Drug susceptibility testing is recommended at baseline, and then you don't really need it unless the patient's culture remains positive at the end of intensive phase, at which case it is recommended to repeat drug susceptibility testing at the next follow-up. Another reason weight is important to be monitored monthly is that all of the drugs are dose based on weight, so an accurate weight is needed every month and the dose must be adjusted based on that. For the liver function test, only at baseline, unless there were abnormalities at baseline, symptoms consistent with hepatotoxicity develop, or for patients who chronically consume alcohol, take other potentially hepatotoxic medications, or have viral hepatitis or history of liver disease, HIV infection, or prior drug-induced liver injury. And lastly, for infection control, isolation is very important. Isolation takes place in specialized negative pressure hospital rooms. And in order to remove respiratory isolation, it's required to have 3 consecutive negative sputum smears collected at least 8 to 24 hours apart. And at that point, the patient will be considered non-infectious. For drug-susceptible tuberculosis, it typically takes 2 to 3 weeks of intensive treatment for the patient to become non-infectious. For some patients, this might be faster. So some patients may become non-infectious within 5 to 7 days if the AFP smear is negative at baseline. On the other hand, it may take several months for patients with multi-drug resistant tuberculosis to become culture negative. Now, when a patient's sputum smear is negative, the risk of transmission is reduced, but it is not zero. So that's important to keep in mind. So such patients can be removed from respiratory isolation, but they must be careful not to cough on others and should meet with others only in well-ventilated places. So smear negative patients still may be culture positive, so they still can transmit tuberculosis to others.